Afternoon, everybody. It is Thursday. This time it's April the 28th, and it's THCB Gang. I'm Matthew Holt, your host and publisher, but I'm not going to be much of a host today because I just came down with COVID and I'm feeling a bit rough. So I'm going to dump that on Kim Bellard. But today we've got Brian Klepper from Worksite Health Advisors down in Charlotte, North Carolina. Michael Millenson from Health Quality Advisors, and him, Brian, by the way, have worked together on and off for ages. So interesting bit of history there in Chicago. Mike Magee from Connecticut, and Kim Bellard from the wilds of Cincinnati. And here's how it's going to go. I'm going to hop off. I'm going to let Kim take over to do the standard go around the horn and start off. Plenty of stuff for you guys to discuss today. And I will try to, this has been the longest I've spoken without hacking and coughing for about a day. So I think my chances are up. But I will come back right at the end to say goodbye and thank you. And with that, Kim, take it away, please.
Well, first, I think we should do the over-under on how long we think Matthew can stay off without talking. I'm saying I got 20 minutes. So let's first go around and talk about what people have been hearing and recently. Brian, why don't we start with you?
Oh, you mean about the world in general?
The world in general. We'll get to some of the specific topics after we do that. But first, do a quick round about what you've been noticing lately.
It would be a great day to talk about the role of venture capital and private equity in healthcare, and the specific case of Livongo and Teladoc.
And you're mentioning the huge drop in value they had today.
Teladoc is down to 10% of what it had been.
Yeah.
And they took a $6.6 billion impairment charge off of the $18 billion that Teladoc spent on Livongo. Apparently, nobody ever looked to see whether what they did actually worked. So it's an interesting day.
Yeah, let's definitely try to get back to that. Michael, how about you?
Well, of course, the big news is that the pandemic phase of the pandemic is over for the moment, according to Tony Fauci.
Tell that to Matthew.
Yeah. And of course, nobody should worry the fact that everybody's going around maskless and acting like the virus has disappeared. That won't cause a resurgence, will it? I mean, it's only done that in Britain and every place else. So I guess we'll just have to wait a few months. The other interesting thing is the American Hospital Association put out a report this week talking about the dire financial situation of hospitals. Now, it is the American Hospital Association, so they're never going to put out a report saying we're making tons of money here. But having said that, there was a lot there that rings true, right? And really an interesting statistic was that a third of hospitals have a negative operating margin. Now, what they didn't mention is that during the pandemic, some hospitals did all right because they got those extra payments. A lot of them did not, but they didn't mention the ones that did. But nonetheless, the pandemic left an enormously stressed workforce, higher prices for the workforce, higher prices for drugs, higher prices for everything else. And when I talk to my colleagues who are consulting out in the field, they talk about the stress being felt by hospitals. So I think that's a real warning sign that even here, when things are relatively calm, hospitals are under stress. That's a real sort of flashing yellow light that we ignored our peril because correcting those kinds of things is not done instantaneously.
Well, if Matthew were talking, I'm sure he would point out about operating income is all well and good, but what about their investment returns that help smooth that out?
That's true too. There's a local health system that the doctors used to refer to as the mutual fund that owned a hospital.
Yeah.
But nevertheless, I think some of the stresses are real. Even when a friend of mine some years ago used to work for the American Hospital Association, used to describe their approach to Congress as whining for dollars. But, I think in this case, they have a legitimate worry. You can argue about the parameters, but I do really think they have a legitimate worry.
Yeah. Mike.
Well, it's interesting, Michael. You're bringing me back to the decade or so that I spent in hospital management, usually with oversight of physician and patient services. And two things that were absolutely consistent through that decade were, number one, the doctors all said that they were going to quit medicine, but never did. And the hospitals, all the way up to the AHA, were absolutely convinced that they were being abused and going broke,
Right.
neither of which proved true, But I think what is true is that the system itself, including the hospitals and the academic centers, were not able to withstand the demands of the pandemic. And what's interesting is if you go back to the CDC self-assessment in 2019, just months before COVID hit in earnest, in that paper, they predict that were we to have a serious epidemic in this country, that the system would collapse. It wouldn't be able to share either human resources or physical resources and get materials where they needed to be. So I think it's kind of fascinating that inside of the health establishment of government, this was predicted, and yet nothing really changed. And in general, I sort of feel that that's the truth now. I did note, by the way, that both Fauci and Birx are beginning to reappear. I think it is time for Tony to take a well-deserved rest. He's over 80 and there's a lot of pressure on him, and his communication expertise, which has been remarkable for decades, I think is beginning to fray a bit. And as far as Birx goes, my feeling is that the very first time that it was evident on camera what was going to happen, she needed to walk away, and she never did. So I'm not that interested in hearing from her now when, on the horizon, we may have this crazy guy running for president again. So I'm kind of done with the old establishment, and I'm looking for new leadership throughout government to handle some of the stresses that are obviously going to come in the future.
I agree with you completely, Mike. Although I think we could also agree that Fauci should not be replaced by, say, Rand Paul.
Right.
Well, several Republicans said that Fauci should be executed by a firing squad and got a standing ovation for that. So let's hope that this well-deserved rest isn't a permanent rest.
Right. Well, that's a difficult thing here, because obviously Tony gave it his best shot. And, looking back on the last several decades and when I was really active in healthcare, I was heavily involved with communications, and this guy was the best of the best. He really managed with things like anthrax and so forth to bail out government when it misstepped on communication. He's been an asset. But the reality is that we're all getting older. And, you can get a little bit too caught up in yourself, and sometimes you need to know when it's time to walk away. And I sort of feel he's reached that point.
So Mike, do you have an opinion? I'm not trying to cut you off, Kim, but I'm just wondering whether you have an opinion about Ashish Jha or in the new thing. I mean, I've known Ashish for many years, and he is a very capable communicator, not as well versed in some of the other aspects, but he's always been a really, good thing. But any opinion on him one way or the other?
Yeah, I mean, with Ashish, I have my oldest granddaughter's at Brown, and a daughter-in-law is on the faculty at the medical school. I was on a advisory committee for the new governor with Ashish a year or so ago. And what I was impressed by, not only like everybody else watching him on TV, he's an excellent communicator and measured, and comes across as the doctor that he is, which is important to me. But in addition, he's a pretty good politician.
Exactly.
And to allow himself to be drawn into places where he's going to get fired upon. So in terms of interacting with Congress and so forth, I think he'll be good. Now, whether he'll be happy a year from now that he took that job, I don't know. I imagine it's going to come with a lot of frustrations, not the least of which is the fact that, number one, the epidemic is not over, and number two, the next epidemic is just around the corner. So, the reality is we're not really prepared in terms of our healthcare system to manage this strategically or otherwise. So I'm rooting for Ashish like crazy, but I expect that within a couple of years, he'll be saying, I like that post as the head of public health at Brown, and I'm going back to it.
Yep.
I want to go back to what Brian introduced it earlier about. So is telehealth dead? Is the digital health marketplace exuberance bubble crashing? Or is this just a company specific issue? Brian, some of your thoughts? I think you're on mute.
Sorry about that. No, I think it raises a flag that should have been raised all along, which is wild amounts of money being poured into healthcare organizations, and the things that they're watching are how many lives they have at the particular moment under management, and nobody's paying any attention to whether what they do actually works. And I think that what has happened is that corporate America, Livongo's clients, realized that what they were doing didn't have any value, and they all began to pull out. And this organization that sold for $18 billion suddenly is devalued after Teladoc had bought it. I think that there's a larger issue that has to do with private equity and venture capital in healthcare as a way of inserting itself to be a new set of pigs at the trough, particularly with physician groups and primary care, where after everything is the deals are done, they still expect to get 22-23% margins out of it for them first, and at the expense of the docs and their patients. I think this is a very, very bad trend in healthcare, and I'm not sure that there's anything we can do about it. But the relationship between the money in Wall Street and healthcare as an enterprise, I think really deserves a lot of scrutiny, but it'll be very hard to fight because they have the money and Congress will do whatever they say.
Brian, do you have an opinion about telehealth being overhyped?
I don't think telehealth is overhyped. Actually, I think telehealth is a new, very effective channel for handling certain things. It can't be, it's not a panacea. It won't address. Sometimes you got to put your hands on a patient, but it's very effective. It's very good in rural areas. It's very good in allowing people to not have to take part of their day and go and travel and sit in an office and wait and so on. I mean, it's an important new element of the of how people practice, but it's only a thing.
Yeah, so I was wondering, and Mike, you might have a more informed opinion, but I mean, I've seen some things that worry that the physicians participating have an incentive to do a bit of churn, right? The old fee-for-service model, in essence, that the more people I see, the more money I make, and I see you briefly and I write a prescription, right? And now you're happy. And so I think there's been some indication that there's a concern about whether the physicians involved, are incentivized to kind of go relatively quickly, write a script and go on to the next person. But Mike, have you heard anything about that one way or the other?
Well, it's interesting, Brian, you and I expect both Kim and Michael have a lot of opinions about the strengths or weaknesses of the primary care base.
Yeah.
You remember back, it's probably now decade and a half, 2 decades ago, when the AAFP, the Family Practice Association, Family Medicine, went through a soul searching that lasted over a year or so to get to the point where they renamed themselves the American Academy of Family Medicine and refocused on what they thought would be the role of family medicine. And I think they embrace this notion of kind of coordinator plus, that not only would they be coordinating the care and therefore add efficiency and continuity to the care, but that in addition, they would still be hands-on. They would still be processing fear and worry. They would still be reinforcing family relationships, as well as helping patients point to the future, a hopeful future, be more productive, and so forth. But I think that the reality is, and what concerns me, is they're really kind of getting squeezed out of the equation. And part of it could be telehealth, although I think at the end of the day, unless telehealth is more humanistic, maybe through voice conversations rather than print conversations, and maybe through an enhancing of somehow this human touch side of things, that they will be a relatively splinter kind of operation and will continue that way. But more concerning, I think, would be 2 things. Number one, the specialists are getting better at continuity of care, and therefore you get handed off more quickly, for example, to your cardiologist, who's able to do a range of things before going back to the family practice person. And since the records are all integrated, yes, there is a function of the record itself being the coordinator of care. And do you really need a full-blown family practitioner, or could that be a PA or a nurse practitioner instead? And finally, then in addition, you've got the pharmacy companies and an expanding role for pharmacists themselves to give you more convenient, immediate response. I don't know how it is in your guys' areas, but in our guys' areas, the family practice are not that good at an immediate response. So, if you're like Matthew and you come down with COVID, he's going to have trouble getting into the office this afternoon, but he can get into the CVS doc box there. So in any case, for me, it's looking to me like the generalist is getting squeezed out, and there's a lot of people vying for that coordinated role. Some of them are alive, and some of them are computerized.
I think there are a range of models that are primary care focused, that are still relatively new, and they're of a variety of designs, ranging from IORA and organizations like that, all the way to Walmart, which now has Walmart has essentially brought in a team to focus on managing risk of individuals and groups. And they view primary care as a platform to manage full continuum clinical and financial risk. And I think that there will be a lot of uptake of that. I think the model that you've described, which I see locally as well, I agree with you, but I think it's a holdover of the fee-for-service system and the influence of the RUC, the RBRVS Update Committee, is part of the AMA, which has plagued us for almost 30 years now.
Michael framed the question as, is telehealth overhyped. And I would probably reframe that. I don't think it's overhyped. I think it's underhyped. I think the problem is that, during the pandemic, people were happy to do it, but we've never really changed the system to figure out what the appropriate role for telehealth is. And now it's bumping up against all the traditional ways of doing business, all the traditional reimbursements, and we haven't really made a place for it that makes a lot of sense. So that it's rough waters these days.
Well, the other thing is the difference between telehealth as done by the health system that you have a relationship with, and telehealth is done by a Wall Street dependent vendor like Teladoc that's getting who knows who to do it in their spare time, right? I mean, that's the other thing. As I've said on this program before, I believe that we should require all Republicans who are in favor of the private enterprise system to get their medical care at for-profit hospitals. Maybe their doctors should all be owned by private equity groups. The kids can only go to for-profit universities.
And all the Republicans that talk about socialized medicine should vote to abolish the VA.
Right. And by the way, mom has to go to a for-profit nursing home. So gotta eat your own cooking. But I mean, I think there's a difference between maybe what a Teladoc does or some of the others, and is it being done by my own health system? But that also goes to your point, Kim, is that it's sort of like, if you're, where you stand is where you sit. If you're a Teladoc, telehealth is, we can keep on expanding. If you're a traditional healthcare system, the inertia pulls you back towards the traditional visit, and neither group is looking. Let me rephrase that. Some traditional providers are now very forward-looking and are, in fact, trying to consider what's the best hybrid model. I mean, there's no question about it. Some of them are very thoughtful about it, but most of them just revert back to where they were, and just like some of the telehealth things. So I think the thoughtful combination of when do I need somebody there and when can I talk to them on the phone is something that I think you're right, Kim. We hope evolves, but given the speed at which healthcare changes, maybe it'll take a while.
I see it getting traction and accelerating as long as it's under value-based arrangements.
Right.
And I think, to go back to what Mike was talking about, I think that the problems that hospitals are experiencing and all providers are experiencing as a result of the pandemic, 1 in 5 healthcare workers has quit in the last 18 months. To replace them, you got to pay them more. You got to pay the people more who stuck around so that they don't stray. And the hospitals and the nursing homes and the practices are going to go to the payers, and they're going to say, we need more money than we've been getting, and that's going to be on top of the double general inflation that we've had for 35 or 40 years. That's going to be a new hit on the purchasers, and I think there are going to be a bunch of purchasers who fall out of the system as a result, and I think it's going to have really far-reaching consequences.
Well, you guys know the economics of all of this far better than I do, but from the standpoint of just everyday patient kind of point of view, what are they looking for? They're looking for convenience a lot of the time because of the immediate day-to-day needs that they have for they and their family. In some cases, they're looking for physical contact, or at least contact with a voice, so that they can be reassured and get access to either testing quickly and sometimes therapeutics quickly. And once in a while, they're looking for real expertise, both on the part of the clinician and the institution. So if I have a heart attack, I want a good hospital and a good cardiologist, right? And I know as a practical person, like most everyday practical people know, that kind of has to be planned for a little bit, right? You've got to sort of, you're way ahead of the game if you're in a system that has both of those things, a good cardiologist and a good hospital system. But that happens only rarely. That might happen less than 10% of the time. 90% of the time, I've already made the jump. I don't really care whether it's a physician, primary care doctor, or a nurse practitioner, or physician's assistant. Most of the things I need assistance with are not that complicated. Somebody's got to look in my ear. Somebody's got to prescribe an antibiotic. Somebody's got to make sure I don't have pneumonia, right? I don't care who's on the end of that stethoscope at this point, as long as I can see that person same day. So, I still think we haven't quite made that jump. I think the biggest thing for me is that academic medicine has been left off the hook on all of this. So, like, for example, I was wondering what you guys were thinking about this whole McKinsey thing, right? Everybody jumps on McKinsey and says, how could they possibly have been consulting for Purdue Pharma at the same time as the FDA? And my reaction to that is, don't blame McKinsey. They're just the glue in all this. Blame the guys in academic medicine who are on every side of this, whether it be the hospital systems or the government or corporate science. Those guys are the ones who are paying the bill. And yet, when we discuss health reform, somehow those guys are invisible, and as if they weren't playing a role, when in truth, they made this whole thing. They created it. So in any case, I just still see there's an enormous widening gap between what we as everyday Americans want and need, which is most of the time pretty simple, and what the other guys are building.
You probably saw the article in Stat News by Bob Herman about the surgeon who is trying to find ways to get around the surprise billing law because $400,000 is not a living wage. Of course, I'm thinking, like, a surgeon's making only $400,000 a year. What is he doing wrong?
Yeah. I had a colleague once during the height of the HMO power, who would talk about the fact that it really, an orthopedic surgeon, really wasn't worth his while to do some of this stuff. And I'm thinking, exactly. So what's the range in which it's not worth your while anymore to see patients? 400,000, 500,000, exactly. Where's the breaking point? But Mike, tell me more why you think academic medicine is getting off scot-free. I mean, wouldn't they say, look, we're just having independent academic doctors who are, serving as advisors to hospitals or advisors to pharma, advisors to the FDA. Since we're the best and the brightest, we're doing what we're supposed to do. We're telling people everything that we know.
Yeah, I may be a little hard on them, but my bias comes from the years I spent as head of global medical affairs for Pfizer. And my major learning in that experience is that my job was too easy. Everybody had their hand out, and everybody was ready to fully cooperate. And they did. My other major learning was that the career ladder was totally integrated between academic medicine, corporate science, and governmental medicine.
Really?
That basically all of the guys that I had, and I ran all the advisory committees, all of the guys that were taking our money and on those advisory committees had been at one time or another at different stages of their careers in one of those three spots. And that progression of their careers was enabled in and out of those three rungs of healthcare. And as a result, you got along by going along, and they all did it. And they all believed that they were not conflicted. They all believed that they had not sold out. But the truth of the matter was that they were all contributing to what had been created. And so when we dismantled through lobbying programs all of the regulatory checks and balances, all of those academic medicine guys, they didn't necessarily speak up for deregulation, but they agreed not to say anything. They went quiet. And
Brian,
that was, most of the time, that was the objective of the lobbying programs, not so much that an AMA wouldn't give you trouble, but that they would stand down when something was happening that could potentially have adversely affected patient safety or something else. They stood down.
Brian, you may have missed Mike's great quote here. Everyone's got their hand out.
It's true. I have a lot of experience with the primary care societies, and they've all sold their members down the river because they want to stay in good graces of the AMA. That goes for AAFP and ACP and the gerontologists, and I mean all of them. And it was very disheartening to see. And yes, they aspire to management of complexity and getting beyond where they are from gatekeepers to becoming advocates and guides. But they've been their own worst enemy in making that transition and helping the rest of us fix that problem. Well,
speaking of gatekeepers, turning to another topic, I think somebody touched upon this early on. The new report from the HHS Inspector General about the Medicare Advantage plans that found that I'm shocked that there are pre-certification issues that medically appropriate care is getting denied. Any thoughts about this report and what it means for Medicare Advantage?
Well, I think Brian and Mike both answered that question actually in another context. The Medicare Advantage plans have terrific lobbyists. We all know that the privatization of healthcare must be a great advantage, especially if, I don't know, you're from Kentucky where Humana is, or from any of the places, the many congressional districts where Optum and United is. And so I think that the facts are entitled to their opinion and the politics are entitled to their opinion. And I think the political opinion is going to be Medicare Advantage is great. So I'm not sure this is going to affect anything. I mean, we've already seen beyond that. We've seen the upcoding. We've seen the Wall Street Journal had an expose a few years ago about if your ratings, if your star ratings are going to be in the tank, you merge that plan with another plan you own, and then you take the better star rating to get it up. So I think that Medicare Advantage. Well, let me stop. Just listen. The name of that is not Medicare Managed Care, my friends. First, it was called Medicare Plus, and then the Republican Congress made sure it was called Medicare Advantage. You know, do you want traditional Medicare or do you want Medicare Advantage now with more benefits, right? So, you know.
Well, first it was Medicare HMO until that became a bad term.
Yeah,
right.
Medicare Advantage. In fact, maybe we could rename some other programs that way, and we should rename Medicaid Medicaid Plus. So I fear that the lobbyists that Mike and Brian talked about will dampen down any urge to actually act on that information.
All that said,
yeah,
I would have to say that I've never in my career been so optimistic about the future of American healthcare. And
I agree with you, Brian, but not because of the lobbyists.
No, not because the lobbyists and the lobbying system is the biggest cancer that we have on the system.
Oh, I have to make a disclosure. I was a lobbyist for Humana for one day.
I want to hear about the cause of Brian's optimism.
Okay, go ahead, Brian. I'll tell you about my brief lobbying career after that.
Because there are more and more and more self-funded employers who are getting behind risk-based arrangements that force the vendors to be accountable. I had a client earlier this year, which was the state of New Jersey's state employee health plan, 822,000 lives. And we got into the data and we were able to show the state that they had been taken to the cleaners repeatedly by Horizon Blue Cross, and Aon had stood by and just let it happen. We showed them that if they stopped sending to every hospital and just said to the best 25 hospitals that they could save enormous amounts of money. They were spending $5.7 billion on their group, and we showed them that they could do it for $2 billion less. And now you've got the state of Connecticut on their state employee health plan has now moved to bundles for all surgeries. So when you start getting big groups like this that are making big changes and doing it in a better, more transparent and accountable way, that's profound. I'm doing work with an ambulatory surgical center company that is a subsidiary of Optum. And I said to the CEO, I said, how do you square the fact that if you do a better job under a value-based arrangement, United makes less money? And she said, because there's been an acknowledgement that the value-based approaches are getting traction and they're accelerating, and we're one of the exemplars to show that we can do it too, and that's the direction that we're going to go. Now, do I really believe that they're all willing to make less money? No, but there's a different set of rules that are beginning to apply, and that's all very positive.
You and Dave Chase need to talk.
I wrote the foreword on Dave Chase's first book.
I do think, though, the one thing I would say in terms of that, well, which I agree with in part, is that it's awful hard to envision long-term success when you're competing head-on with a major Fortune 100 company.
Yes.
It may appear as if you won, but somehow within a year or two, they managed to find a way around what you think you've accomplished. But I do share the optimism only because I think that where we will end up heading, at least for 90% of the care system, will be toward convenience. I think this pandemic has reinforced, for example, work for home. Why? Because it makes sense and it's convenient. Who the hell wants to spend an hour or more in a major metropolitan area commuting most of the time to something that has no particular value in having you next door to your co-workers? No, you want to stay at home. The people have put in their home offices, and a lot of them are going to stay there because it makes sense. Similarly, for most of the everyday challenges that we have that are health related, that either need preventive strategy, coaching and encouragement, or simple interventions, those things can be more easily done by my neighborhood drugstore than they can me trying to figure out how to get through the phone tree of some doctor's office, which really isn't any doctor's office anymore. It actually is XYZ Health System, which has 800 doctors and has proliferated a bunch of people to run their phone system who aren't interested in speaking to you on the phone. So, it's like, this is not that hard to compete with, right? And so if it's laying right there and I can get to it quickly and it's going to be reimbursed by my insurance the same way as if I waste a half a day trying to get an appointment, can't get it till tomorrow. Once I get there, I got to wait an extra hour and I don't see a doctor anyhow. Why would I want that? And so then the only question is, okay, if we have this integrated record, if we have advancing information systems, if somehow we're okay with giving up the issue of privacy, because, hey, we're out of the area of surveillance anymore. They capture all our data anyhow. As long as it's transparent and as long as it gets me to a quick solution by someone who is reasonably prepared, I'll go with that. I don't need the MD anymore.
Well,
Now, again, the only problem is if I got something really serious, I want to be able to have an existing pathway into acute treatment. And I think it's in that area that maybe value-based really takes off, and it really is around a coalescence of specialty skills that you can access if you're in trouble.
Matthew would be disappointed if I didn't express my cynicism about Brian's optimism. So 30 years
That's
ago.
okay. Michael's on the phone here with us,
So 30 years ago, large corporations were pushing their employees into narrow network plans with great enthusiasm and demonstrable savings, but it failed because employees didn't want to do that. Employees wanted convenience more than the value. And, as Michael and I have talked on previous things, the most important thing to a benefits manager is not whether it saves money, but how many employees are complaining. So until you can actually move into value-based things and employees see that they are getting demonstrably better care, it's not a sell to them. Convenience will win out. And that's where I think we've failed. We have not really convinced people that it matters what hospital you go to, which doctor you see, and that we're in your best interest to send. I think employees still think they're sending me there because it's better for them, not better for me. And that's a big hurdle we have not addressed.
And there was a saying when I was an HR consultant: make sure the CEO's wife's gynecologist is in the network.
Right. I was just thinking of that, Michael. When I'm from a family of 12 and my wife's a family of 10. So I'm forever trying to help people find the right doctor, right? And what do I do to do that? If I don't know an area, I don't know a town, I call a local hospital or an academic facility, and I talk to the staff nurse in the ER. And I convince the staff nurse in the ER to tell me which cardiologist she would go to if one of her family members were in trouble. And it works because they know, you know what I mean? So the only question I have is, how does the CVS or the Walmart or whoever else is right next door to me that I can get to quick, how do they get access to that network, right? How did they know who to refer me to if I have chest pain?
They have two approaches. One is they are on the hunt for very high performing healthcare organizations within high value niches. By high value niches, I mean, who does the best job in musculoskeletal care? Who does the best cancer care? Who does the best management of specialty pharma, and so on. And when they don't have any good answers in that, they punt down to using performance data from Embold and other organizations like that on the docs, and they go after the high performing docs within each local community, and they refer specifically to those docs, to the docs who consistently get the best outcomes at the lowest cost.
Now, has anybody ever used a low-tech method? Like, for example, let's say you're in suburban Boston, outside, Brookline or something, and you've got a collection of 50 outlets that have, doc box kind of things. Has anybody ever hired somebody to scout out and create, by reputation, a network of referring doctors, and communicated with them that if you get a call from us, you have to respond same day? Has anybody taken that kind of a low-tech approach to building
they have for 30 years, but data works better. And the issue at the end of the day is can I get data that demonstrates that I'm going, if I tap into the following people, I'm going to get the following better results. I mean, for the last 8 or 9 years now, I've focused all of my energy on identifying healthcare organizations that consistently get better healthcare outcomes and or much lower cost in high value niches, like I've described. The companies that I find are spectacular, and they get great results, and they are willing to guarantee their results. So integrated musculoskeletal care out of Tallahassee, Florida, will financially guarantee a 25% reduction in MSK spend with better health outcomes on the patients they touch. A 25% cost reduction in that space translates to a 4 to 6% reduction in total healthcare spend, but more realistically, it's going to be double that. It's going to be 8 to 12% reduction in total spend, because they're only going to guarantee half of what they know they can deliver.
But getting back to what Kim said, do the patients like who they're sent to? You know what I mean? When I was a rural doctor, that was the bottom line. The patient left the office and told his neighbors, I like that guy, or I didn't like that guy. You know what I mean? And hopefully they liked him for the right reasons, but a lot of it was not particularly measurable. It was just that they had connected and they trusted and they felt better, right? So even with the Press Gainies and all of the surveys and this and that, I've never seen yet something that competes as well as a neighbor saying this one's great and I should know, I'm a nurse. You know what I mean?
No, you're absolutely right. And keep in mind that the health plans have sold choice for a long time, and they're very good at it. But at the end of the day, it does nobody any good to have the right to go to a lousy doctor.
Right.
I am optimistic because I think data is starting to become mainstream. And one of the things that's a little bit obscure but is important is at the end of this year, the information blocking regs that take effect say that all the patient's medical record has to be available to APIs in a FHIR compatible format, which essentially opens things up to apps, which opens things up to platforms, which opens things up to more analytics. And that's tremendously important, but kind of hidden. The problem is, in fact, that the patients do not necessarily see the difference in outcomes, right? That people judge it by, I'll give you an example. I mean, the patient safety advocates who I know who have been harmed and are advocates are generally middle-class people who went to hospitals that have great reputations and beautiful atriums, right? But in general, they don't talk about the name of the place, right? So even the big medical mistakes are not visible, and the smaller outcome problems are not visible. And so it's very difficult to compete against this halo effect. I have an article that's sort of in press at an op-ed where I talk about transparency, that we should display the data in Maslow's hierarchy of needs rather than these spreadsheets. Will I be safe? Will I be heard? Will I lead my best life? Right? Patient-reported outcome measures. Am I being listened to, experienced, and am I going to be safe? And am I going to be, really get the care that I need? And we need to talk about the kind of data that Brian is talking about in a way that emotionally resonates with patients, and we don't do that. It's difficult, but I think we need to start to have things where we connect directly on the data. So I am optimistic, although when it comes to corporate America, I'm optimistic about the people that Brian is dealing with directly. I'm not sure about the other 98% of the corporate world. But anybody who hires Brian, I'm optimistic about.
Yeah, Michael is right.
So when I read the Medicare Advantage article, my thought wasn't, oh gosh, those Medicare Advantage people are denying a bunch of appropriate claims. My first thought, of course, was, well, I wonder how many medically inappropriate claims are going through traditional Medicare, And the patients think that's good. My doctor's doing everything he can for me.
Absolutely.
And they're getting subpar care and thinking that their doctor's great because of it.
And by the way, my doctor charges higher prices because he's better, because that's what he told me. So lots of care at high prices is good, unless, you know, you're like the one paying for it.
Yeah, but I still think that the continual advance of integrated electronic medical record, where you have access and you're actually at some point going to be the one who's coordinating your care between various different physicians and institutions, is going to advance more patient-centered choices. You know, people will probably still rely on neighborhood networks for recommendations of who's good and who's not good. And the difference is they may have the power to make the choices, because it really doesn't matter what practice they're from or even what hospital they integrate with. The data is going to flow to your integrated record. You basically have built your own system, and you don't. That's why I say I'm not seeing a bright future for primary care, because that gatekeeper role is basically embedded in the record that patients increasingly realize they have on their own computer.
And the employer, this is where I think sometimes physicians underestimate consumerism, is you go, well, you know what, that's great for the highly educated people, but other folks can't deal with that. But the employers are providing companies that provide the navigators.
That's right.
And they have the incentive to do that. So, you know, the guy on the loading dock is going to have access to sophisticated management help from some of the vendors that do this, because it's the employer's interest. And the other thing that's interesting in that same context, a little different from what Brian's saying, but complementary, is proactive benefits, right? Where we come out there and we say, we're going to help you with IVF, or we're going to help you find the best care. And there's a company, for instance, that I find really interesting, Potentiometrics, that has outcome measures on cancer care for millions of patients, then throws in your personalized data and says, what's the best care? Well, again, this is not the kind of thing that the providers buy because they want you to come to their hospital. We're the best, but it's the kind of thing that's attractive to employers and maybe plans if it's not their network. So I agree with you.
What's happening too is that because there's everybody's living longer and you got long-term care, people like me and my wife in our 70s are caring for siblings who have long-term care problems and may be in an institution. Managing that is at least as complicated as when we managed our own children's health.
Yes.
So, and we're forced not only to manage, but to advocate for these people who've been entrusted to us. So we're putting pressure on these organizations to step up to the plate. So for example, I never knew that with hospice, when you sign someone up for hospice, the reason you're getting an increase in government funded services of all types that you don't get under Medicare is because you have agreed to never send that person to the hospital or do anything to save their lives. That saves the government money because you're committed to the person dying, right? And that's the deal. You sign a contract, they provide additional services that they pay for in return for you not treating the pneumonia and not treating the sepsis and not taking them when they fall on their head to the emergency room. That's the deal.
They should call hospice Medicare Advantage.
That's right. So nobody talks about that. And after all these years, I only just recently learned it because of consumerism, right? They don't talk about it because it sounds so crass, but that's how the system works. So what I'm saying,
a lot of private
like we are learning, you know, this is how the system works.
A lot of private firms are getting into hospice. Unfortunately, what's happening is they don't necessarily provide as many of those services as you think you're getting either, right?
Right. Yeah, there's a lot of fraud.
Yeah, or kind of
I mean,
like,
in the sense that they say we visit 3 days a week.
right, they don't, exactly.
You
They
know,
don't fulfill their part of the bargain. They cut back on all that, right? So I think what this tells us is that it's a really good time to get into the for-profit part of healthcare. Don't you think that's the, what we're talking here is about how you can make money off of hospice, you can make money off of owning primary care doctors, you can make money off of pretty much every part of the system. And as you make that profit, you should make sure to say you're making the system more efficient and effective.
Yeah,
I'd say yes, but I'd say if you're doing it in a way where patients say, you know, this really helped.
Right.
That will be lasting. If you're doing it just because you save somebody who already has a lot of money more money, I don't, and it doesn't provide any additional value to the patient, I don't know whether a company like that's going to last.
Oh, well, the transactions that are going on now, I mean, the chief lobbyists against the surprise billing regulations was Wall Street that had stakes in large physician practices and in emergency docs and other organizations like that. It's a pure financial play, and it is ruthless.
Yeah.
And usurious. It's a terrible trend.
Okay, so we're getting near the end of the time here. So now we'll do our quick little go around about what you're looking at in the next week or two. Mike.
Well, there's a 1994 paper by Phil Agri that was called Surveillance and Capture of Two Models of Primary Care that focused for the first time, this is back in 1994, on the difference between a surveillance kind of approach to getting data and a capture. So he basically predicted everything that has happened up to the point of unreliable data as well. And so it's in a magazine called Information Society that he published, and it's searchable. It's worth a read because, you know, he called it right. He predicted what would happen. And I still think we need to think hard, you know, what is this business of capturing data going to finally land on in healthcare?
Okay. Michael.
Well, obviously, COVID is still pretty much a big concern. And actually, when it comes to capturing data, I've written about the secret analytics being used by MA plans and health systems, where they capture non-protected data, like from credit bureaus and all the rest, and suck it up with hundreds or even thousands of variables on each of us. And that has not gotten much play, despite my sounding the alarm and a couple of others, because it's not as obvious as a Google. But I think that, you know, the good side of data is exactly what you were talking about, Mike, about the integrated record and what Brian's been talking about. But how will the average person react when they find out that their personal data is being used for their own good by their health system and by their doctor? And I think that they're going to react with perhaps some skepticism about whether it's for my own good is a good excuse.
Okay. Brian.
You know, I've spent my whole career being skeptical of the system, like we have all become. But I've over the last 5 to 10 years, every day I discover that people are doing great things that have tremendous potential. I'm working with an artificial intelligence company now that guides physician prescribing for major chronic diseases. And is moving control rates from 45% to 95%. Spectacular stuff. So, you know, I'm still very optimistic. Maybe naive, but optimistic.
Well, naive is something that I doubt many people accuse you of being. I'm hoping that perhaps we can persuade Brian to play that piano in his background, because I've been fascinated with that the whole call long.
Well, another time, that piano was my late wife's. The only difference between me and her was that I played, but she played well. So
Indeed, I remember Elaine well. Well, everybody, thank you so much for doing one without me. It was probably better, I suspect. I was hacking away and coughing during that, but you guys went through some great, some really exciting stuff there, including, is telehealth real, not real? Is primary care real or not real? And Brian's going to be optimistic, which is great. And I hope so. Although Michael, I think when we start our hedge fund and give you all the money to do private equity, you may be working against the best interests of the system. So I'm going to pool all the money I have after my Teladoc stock is left over. While you've been gone, while you've been on and I've been off, this showed up. So I now have my Paxlovid. I've taken the first one. So thank you, Pfizer and Joe Biden, for paying for it. I hope Joe Biden paid for it. I haven't seen a bill yet. I'm looking forward to it. But just to let you know, you've been listening to Brian Klepper from Worksite Health Advisors in Charlotte, North Carolina, Michael Millenson from Health Policy Advisors in Chicago, Mike Magee, medical historian from Connecticut, Kim Bellard, who played host this week. Thank you very much for doing that, Kim, from the wilds of Cincinnati. And we'll have some stuff up on THCB from Kim tomorrow. And that is it. I will be back next week. Next week, we're going to have, hopefully, A, I'm better, and B, we're going to have a special episode about cancer care. It's going to have a couple of people from Jasper Health, the new cancer navigation company that's raised a ton of money. And it's going to have 5 people at THCB who've been on the THCB gang many times, all of whom in one way or another have been deeply touched by cancer. So really looking forward to that special episode. But this was episode 9. We'll see you again next week. Thanks so much, everybody, for either watching or listening on the podcast.